Okay, I'm going to start out with an audience response question. So please use your panels in front of you. The question is, how familiar are you with the ACC AHA PAD guidelines? And please be honest, I won't be offended. A, very familiar and refer to them often, eagerly awaiting update. B, somewhat familiar, have read all or part. C, have never heard of them. C, have heard of them, or D, never heard of them, eager to learn. Okay, wow. 20% of people in this room have never heard of the ACC-AHA PAD guidelines. Terrific. Okay, you're going to hear about them quite a bit in the next 10 minutes. Most of you have either heard of them, are somewhat familiar, and only a few of you refer to them and use them often. Well, what are these guidelines? These are consensus guidelines that were actually first published in 2005. Consensus of cardiology, vascular surgery, radiology, medical organizations. And the original publication was in 2005. This document included lower extremity PAD as well as abdominal aortic aneurysm, renal, and mesenteric disease. They were updated in 2011, not all of the sections, and then compiled together in 2013. And actually there is currently a subsequent update being worked on that will be published later this year. So right away my talk is going to be a little bit dated. There's going to be a number of stay tunes. There's another important guideline to know about from our colleagues in Europe. This is the TASC document, which also contains recommendations on CLI management and medical therapy. Very important document. I know you went over this morning, but just to remind you, CLI is really the highest risk cardiovascular subset of patients with PAD. And you can see compared to controls without PAD, compared to claudicants, CLI patients have the poorest survival. I thought this was a really terrific paper. This was published over the summer in the European Heart Journal. This is data on almost 42,000 inpatients in Germany with PAD, and it looked at their outcomes by Rutherford class, 1 through 6. And you can see in that rainbow, red is Rutherford class 6, orange 5, green 4, and blue 1 through 3. You can see for all outcomes, death, amputation, stroke, MI, the higher the Rutherford class, the worse your outcome. So because of this, comprehensive care of the CLI patient is critical. We're talking a lot in this course about revascularization to improve function, salvage limbs, improve quality of life. We obviously need to protect the feet. And what I'm going to talk about is the preventing heart attack, stroke, and death. Briefly, smoking cessation is really the single most important intervention for PAD patients. It improves survival as well as limb outcomes. There's multiple pharmacologic agents to help support smoking cessation. And importantly, studies have shown, this is work by Alan Hirsch's group at the University of Minnesota, that intensive smoking cessation, including pharmacotherapy, can actually improve quit rates compared to just telling patients to quit smoking. And the 2011 PAD guideline update really made an emphasis on the importance of smoking cessation. Patients who are smokers or former smokers need to be asked about status of tobacco at every visit. They need to be assisted with counseling and developing a plan to quit, including pharmacotherapy and referral to formal programs. At every office visit, clinicians need to talk about the vital importance of quitting smoking. And then a 1A recommendation for patients in the absence of contraindication, pharmacologic therapy should be offered, including varenicline, bupropion, and nicotine replacement. I'm not going to talk about antiplatelet therapy. It's critical, it's guideline recommended. We're going to focus on it in the next 4 talks. Lipid-lowering therapy, very critical. Statins prevent cardiovascular events in PAD patients. That's data from the Heart Protection Study. These are the 2005 guidelines. They recommend a statin for all patients with PAD to achieve an LDL target of less than 100, an option for an LDL target of less than 70. These are older guidelines. They also talk about fib rates, which we no longer use first line. I think this is an area that's continuing to evolve. So stay tuned for the 2016 guideline update. I want to briefly mention a few bits of data specifically in the CLI population. This is a group from the UC Davis, John Laird's group. This was a cohort of patients in their registry who underwent angio and intervention for CLI, and they actually looked at outcomes for those prescribed statin versus not prescribed statin, adjusting for other factors. And what they found were that those prescribed statin had significantly reduced cardiovascular events as well as certain limb outcomes, especially limb patency for infrapopliteal revascularization if they were on statins compared to no statins. Blood pressure control also important for PAD patients, directly from the 2005 guideline, a goal of less than 140/90. For diabetics, perhaps a more stringent goal. Importantly, beta blockers are not contraindicated in PAD. They do not hasten CLI. And referring to the HOPE trial, the use of ACE inhibitors is reasonable to prevent cardiovascular events. Again, stay tuned. This area will likely be updated. I again want to mention some CLI-specific data. Honestly, we should have had John Laird give this talk. This is more data from his group, a very nice study led by Aaron Armstrong, and it looked at CLI patients in their database who were prescribed ACEs and ARBs versus no ACEs and ARBs. And again, did some propensity matching adjustment to account for other factors, but found that those CLI patients who were prescribed ACEs or ARBs had decreased cardiovascular events, decreased all-cause mortality, no change in limb events, however. Well, this all seems really, really obvious, but there's still work to be done here. These are two cohorts of CLI patients. The top was the PREVENT trial from 2005. And you can see in this study, at baseline, very low rates of lipid therapy and antiplatelet therapy. This is more recent data from the Blue Cross Blue Shield PVI registry, just published last year. And you can see in their PAD-only patients, only 62% on a statin. They do better with antiplatelet therapy, and only half on ACE inhibitor or ARB. Patients who have CAD as well as PAD, slightly better, but still lots of work to be done. Okay, changing gears, question, please get ready on your keypads. Do you use iloprost infusion to treat no-option CLI patients? A, never. B, once or twice in the past decade. C, regularly, or at least a few times per year. Or D, don't use for CLI, may use for something else, like secondary Raynaud's. Now, it'd be interesting to poll our European participants separately from the Americans, as the paths may differ. Okay, so 3/4 of you never, a few of you using it for things other than CLI, and basically very few are ever using this for CLI. And that's consistent with the guidelines. Unfortunately, there's not much else in the way of effective evidence-based medical therapy to offer for CLI. In the 2005 guidelines, a 2B for angiogenic growth factor, only to be done in the setting of a clinical trial. Iloprost infusion, a 2B. Efficacy is likely to be limited to a small percentage of patients. Class 3, do not use oral iloprost. And Class 3, do not use parenteral pentoxifylline. So not much benefit from iloprost and other agents. I want to conclude with just mentioning two novel areas for CLI. One not so novel, but some novel data on glycemic control, and then a last word about adequacy of hemodialysis. There's been a few small case studies, these are data from Japan, that showed that patients with CLI who have lower hemoglobin A1C levels actually have better limb outcomes over time and lower amputation rates. This is the data from again from the UC Davis registry. These are the CLI patients who were diabetic and had infrapopliteal intervention, and they actually recorded fasting blood glucose on the day of the angioplasty procedure and then stratified the patients by the median blood glucose of 144. And you can see here patients with a fasting blood glucose below the median actually had significantly higher rates of primary assisted, secondary patency, repeat intervention for surgery and amputation compared to those with higher fasting blood glucose. So the 2005 guidelines recommended a hemoglobin A1C target less than 7, mainly to prevent microvascular complications and prevent potentially cardiovascular outcomes. There was nothing in these guidelines about CLI or limb endpoints, so stay tuned perhaps for the update. And then finally, I just want to mention this article published in this month's issue of the journal Vascular Medicine. It's on the quality of dialysis and CLI outcomes. And this was data from 2 centers at Japan, 221 consecutive CLI patients who underwent endovascular therapy. They measured baseline calcium, phosphate, and creatinine levels 3 days prior to their last hemodialysis session, and then followed these patients for a year plus after the revascularization. And what they did is they actually looked at calcium phosphate product levels, those below the recommended product level of 55 or less versus above, an outcome in patients. And what they found in this study is there was a significantly higher amputation-free survival among those with a lower calcium phosphate product. And it was also a predictor for amputation-free survival after adjusting for multiple other confounders. So again, perhaps a future target for medical therapy, better dialysis. So with that, I'll conclude.
So I think this is known to each one of you that the outcomes of patients with CLI overall have not changed over the last decade. This is a slide published in 2000 indicating 20% mortality over 6 months. And I think despite the trends of improved outcomes of patients with PAD in general, the CAD subgroup has remained unchanged. Whenever I think about antiplatelet therapy, and specifically in this instance, for patients with critical limb ischemia, I kind of divide this into 3 big boxes. Why it is prescribed. First, prevention and secondary prevention of major adverse cardiac events. The definition includes cardiovascular death, non-fatal MI, and ischemic stroke. Reducing the incidence of major adverse limb events. I love this abbreviation, MAIL. Cardiovascular deaths, amputation, and need for any kind of revascularization, both endovascular and surgical. And as an interventionalist and endovascular specialist, I do hold dear specific antiplatelet therapy indications for post-revascularization patients, both following surgical and endovascular therapy. So my entire talk is going to revolve around these 3 main areas. While I first show this big overview, I do not intend to go through the pathways of antiplatelet effects of different drugs, simply to highlight that all through this talk and this session and the satellite session tomorrow, the word antiplatelet and antithrombotic needs to be looked into over a broader prospect of agents, because apart from blocking the thromboxane pathway and ADP receptor antagonists, there are also a whole slew of agents that interact with the PAR1 receptor, that is the point of intersection between the coagulation and the antiplatelet pathway, essentially blockade of thrombin action on platelet activation. While I was preparing this topic, I wanted to get this part over with. I think what I've tried to do and what I would like to get your focus on is on varying definitions of CLI in each of the studies that I'm going to review. Second is the combination of different antiplatelet agents is also a very difficult issue. And again, I've tried to categorize them based on monotherapy, dual and sometimes triple, and also upcoming studies that have combined antiplatelets and anticoagulants. The first study that I want to start with you is that we have always thought about why do patients with CLI actually have higher incidence of cardiac events. There are a lot of hypotheses, but this is a neat study where investigators studied the amount of activated platelets. Let me show you on the y-axis of this graphic, activated platelets are scavenged by monocytes. So if you study the amount of platelet monocyte aggregates, you get a sense of how many activated platelets there are in the bloodstream. And if you compare them based upon therapy with aspirin plus placebo versus aspirin and clopidogrel, we do see a reduction in the number of activation on dual antiplatelet therapy. It was associated in a peri-surgical revascularization patient subgroup, reduced number of peri-procedural myocardial infarction, of course, at a slightly higher risk of major bleeding and significantly increased need for transfusion. Following this up, there are some data from randomized clinical trials. I'm sure many of you have not heard this. I had to dig deep to find these. This is a VA cooperative study published in 1986 that randomly assigned patients to dual antiplatelet therapy to placebo at multiple VA centers, looking at cardiovascular death and amputation of the contralateral limb after they had undergone amputation of one limb. As you know, the risk of death is extremely high, again showing no benefit, neither in terms of cardiovascular death nor in terms of reducing the need for future amputation. Please pay attention to the cardiovascular death rates. Again, they have remained unchanged over the last 2 decades in CLI patients. A single-center observational study again looked at aspirin versus no aspirin in CLI patients undergoing infrainguinal bypass. 2-year graft patency and 2-year survival from cardiovascular death was again no different. Again, note the high rates of death rates over 2 years in this patient. And in this single-center study, aspirin was not a significant predictor in preventing graft failure or vascular death. As Dr. Gornick did cite some of the papers from Dr. Laird's group, I'm not going to stay behind. This is a study of patients with endovascular revascularization. And the reason I put this up here for this evening is because 55% of patients in this study actually had CLI. And they were studying with propensity match analysis the effect of aspirin alone versus aspirin and predominantly clopidogrel post-endovascular revascularization on both MACE and male. As you can see on the left panel, there was a significant reduction in the major adverse cardiac events, however, no effect on the right panel on limb-based survival and limb-based events. This is our data from the XL-PAD registry with 30% CLI patient with no difference in death and major amputations with antiplatelet monotherapy versus dual antiplatelet therapy extended beyond 3 months. Though you see a statistically significant difference in terms of need for surgical revascularization, numerically there was a lowering of death and major amputation with extended dual antiplatelet therapy. However, these did not reach statistical significance. I have put together this slide that kind of summarizes many of the prior studies. And I think this is important because in each of these studies, the definition of CLI is very different. In Capri, they predominantly included intermittent claudicants, but they had a 30% of patients that have had prior amputation, prior endovascular intervention, or prior surgery, and they were not broken down in the study paper. As you can see, there was a relative risk reduction, especially in the PAD cohort for major adverse cardiac events. However, these data have since then not been duplicated. In their DEB study, similar definition, but a different drug. Aspirin was compared to not ADP receptor antagonist, but another inhibitor of thromboxane A2 synthase that is called pictomide, and that led to a relative risk reduction of 45% in the diabetic subgroup only. The David study, with a similar design, also had a statistically significant reduction in mortality. However, the largest of these studies, Charisma, which was predominantly a secondary prevention study, had a very small number of patients with CLI, again, except for a reduction in the PAD cohort for repeat rate of myocardial infarction. There was no other known benefit from extending dual antiplatelet therapy. The major bane for limitation of these studies is that whenever observational data have been compared and extrapolated and then studied in a prospective randomized fashion, the event rates in this patient subgroup have suddenly dropped. And that has to do predominantly, in my belief, with different definitions of CLI and maybe not the severity of patient one needs to study and randomize in these kinds of clinical trials. There are two studies that specifically pertain to both surgical and endovascular intervention and the duration and regimen of antiplatelet agents. The CASPER study, done predominantly by vascular surgeons looking at below-the-knee bypass graft patency, again comparing aspirin to clopidogrel plus aspirin in a placebo-controlled trial, showed no benefit overall, except for a small subgroup of patients that had prosthetic grafts. They did benefit with reduced rates of occlusion and repeat revascularization. The MIRROR study done in Germany by Dr. Teppe's group included both intermittent claudicants and CLI patients, and post-endovascular intervention with aspirin and clopidogrel did show at 6 months, which was a primary endpoint of the study, reduced rate for target lesion revascularization. However, there was no benefit sustained at 12 months. These issues are important. And newer studies that have recently been published, again, this is from the follow-up of the Pegasus trial looking at ticagrelor in post-MI and PAD patient. Before I show the data, let me just tell you that the number of patients of CLI in this subgroup is less than a third. As you can see at the very bottom, predominantly intermittent claudications and prior revascularization, only a third of patients, again, showing a very larger absolute risk reduction in the PAD subgroup compared to the overall study patient population. In the placebo group on the right panel, there was a higher incidence of major bleeding. However, there was no increase in major bleeding with extended duration of ticagrelor in this patient population. I'm not going to dwell a lot about Vorapaxar. I'm sure my speaker following me is going to outlay this data. However, these data have been promising and have shown a reduction in acute limb ischemia requiring hospitalization. You know, as you review data for CLI, I found this piece of information extremely helpful. Patients with CLI have polyvascular disease. And given the extent of polyvascular disease, both MACE, peripheral revascularization, and bleeding increases proportionally. So there is a great need for studying the CLI patient per se directly, and extrapolations from prior clinical studies and other clinical studies that have enrolled only a minority of CLI patient populations may not be appropriate. And this is summarized, the bleeding risk of these agents are summarized on this slide. If you look from your left to your right, both with dual antiplatelet therapy, there has been a 0.5% increase in absolute risk of moderate to severe gastro-severe bleeding, which has been there also with Vorapaxar on the backdrop of aspirin or clopidogrel, or with triple therapy that only a fraction of patients received in the study, about 25 or 28%. There are a lot of upcoming studies. Just want to mention that Vorapaxar is approved for a PAD indication. Highlighted in yellow at the bottom is that many of the devices now have IFU-based recommendations for antiplatelet therapy, and a lot of new studies, Voyager, Euclid, and BEST CLI, is going to enlighten us further. Dr. Gornick mentioned the current guidelines do currently only advocate for aspirin monotherapy or clopidogrel monotherapy and give dual antiplatelet therapy both in intermittent claudicants and CLI patients at 2B indications. We are currently conducting this study out of UT Southwestern where we are comparing long-term and short-term dual antiplatelet therapy. I encourage you to look it up on clinicaltrials.gov. It is called ASPIRE, and this is mainly for patients with intermittent claudication and CLI after endovascular revascularization. In summary, my take-home message for you is that for reduction of MACE, I think there is sufficient evidence, or I call it best practice evidence not yet endorsed by the guidelines, for aspirin plus Vorapaxar or ticagrelor. For reduction of male, I would suggest aspirin plus Vorapaxar. I think there is good evidence for it now. I didn't say aspirin, or I didn't advocate triple regimen because only a minority of patients actually received it. For improvement in patency of prosthetic grafts, dual antiplatelet therapy, I think based upon the randomized clinical trial CASPER, would be a reasonable choice. And of course, the dual antiplatelet therapy after endovascular intervention, I think is the contemporary practice, however, the duration of which remains uncertain. Thank you very much.
All right, we'll talk about the heterogeneous approach. I'll just re-emphasize what Dr. Banerjee just said about the heterogeneous approach to pharmacologic therapy in CLI. We'll talk about Vorapaxar and the class of agents in the TRA family, some of the evidence, and then some recommendations. So I'll start with giving you 3 facts. Number 1 is we're in Cleveland, Ohio today. The Cavaliers are actually losing in the 4th quarter. I don't know if anyone's a basketball fan. That's the first fact. The second fact is in PAD and CLI in general, there's a large variation in the use of antiplatelet medications and antithrombotic therapy in general. So saying this a little differently than Dr. Banerjee said, you can see that in a large population of Medicare patients that we studied, and this was before Vorapaxar was approved, you can see that 1/5 of patients were not treated with a prescribed antiplatelet therapy. You can also see that almost 1/5 were prescribed oral anticoagulants, usually for a different reason, atrial fibrillation or prior history of deep vein thrombosis. You can see at the bottom right of the screen that many patients had a prior indication for P2Y12 use, and then a very small percentage got 1 to 30 days of P2Y12 use, and then about 1/3 got greater than 30 days. So the second fact is a large variation. Throw into that a new agent, Vorapaxar. So Vorapaxar is a thrombin receptor antagonist. You can see that it is a PAR1 inhibitor. It is different than clopidogrel and the other P2Y12 agents, which act in an ADP mechanism. And it is a first-in-class agent. This is an old slide, but you can see that it's primarily metabolized via CYP3A4 mechanism. The half-life is longer. And in prior smaller studies, there wasn't an increase in bleeding. So I thought I'd give you the evidence in PAD patients. Dr. Banerjee told you already that most of these patients were not CLI patients. They were PAD patients who had had prior revascularization or intermittent claudication. So here's a slide, New England Journal, Dr. Morrow, the TIMI group, Mark Banaka, presented this and showed that in a group of 26,000 patients, almost 4,000 patients, so 3,800 patients had PAD. They were randomized in a 1-to-1 fashion of Vorapaxar to placebo. About 25% of these patients were on dual antiplatelet therapy at the beginning of the study. The remainder were on single or monotherapy antiplatelets. They followed these patients for about 30 months prior to the end of the study, and they looked at a combined primary endpoint of cardiovascular death, MI, and stroke. They also did a very nice job, I thought, at looking at hospitalization for acute limb ischemia, peripheral revascularization, and then an actual adjudicated endpoint of urgent vascular hospitalization. So I'll show you these results now. I will show you just the PAD cohort results, reminding you that there was a 1.2 absolute risk reduction for the primary endpoint for the entire trial. Okay, for the 26,000 patients, it was 1.2%, at least based on the New England Journal of Medicine publication. In the PAD subgroup, that was pre-specified because it was a large group in the TRA2P population. You can see that the absolute difference was not statistically significant. The absolute difference was 0.6% here, and that was out to a little over 1,000 days. Because acute limb ischemia is something that hadn't been talked about as much before this publication, I think it's important to define it. So it's going to be something that you see more and more often over the coming years. So acute limb ischemia hospitalization was defined by arterial emboli, arterial thrombosis, or arterial trauma from a vascular procedure. And it required one of two things typically: a history that was suggestive of an acute or rapid sudden decrease in perfusion, and a new pulse deficit, something on physical exam that prompted an adjudicator in the CEC to say that this is acute limb ischemia. Or it required the site investigators to actually to look at the limb hemodynamics or the non-invasive or invasive studies to confirm limb ischemia. So an important concept of an adjudicated limb endpoint, something that's really important, and you'll see more and more over the coming years. Somewhat hard to see probably in the back here, but what we have is Kaplan-Meier plots of acute limb ischemia hospitalization, but in PAD patients. In TRA2P, almost all of the patients who had acute limb ischemia had prior PAD. So it, I think, authenticated some of the thoughts of why this was occurring to these patients. Acute limb ischemia occurred in 2.3% of patients with Vorapaxar and 3.9% in the placebo group. That was a statistically significant difference. There was also a statistically significant reduction in the overall number of peripheral revascularization procedures. When we look at combined endpoints, specifically urgent rehospitalization for vascular cause, you can see that the difference was statistically significant as well, favoring Vorapaxar over placebo. And then again, a combined primary endpoint of cardiovascular death, MI, stroke, as well as revascularization or urgent hospitalization for vascular cause, you can see, again, a statistically significant result here. So in general, acute limb ischemia, peripheral revascularization, and urgent hospitalization for vascular cause, all statistically significant and favoring Vorapaxar in this population. I think Dr. Banerjee mentioned that when you look at event rates, something that we're really bad at in the PAD population, the event rates were fairly similar to previous studies of PAD populations, just looking at the annual risk of death, which is about 3%, MI 2%, stroke 1%. So very nicely done in terms of this, what I would say, large subgroup study of PAD patients. ALI, again, something that you're going to hear more and more about, does have an impact that is important for our patients with PAD. We don't know how many of these patients had critical limb ischemia at baseline or progressed from critical limb ischemia and had an acute thrombotic event or something else. On the left-hand side, again, colorful slides, hopefully you can see some of this. The largest group, the red group, is surgical bypass thrombosis. You can see there is native vessel thrombosis in orange, and then peripheral stent thrombosis in this lime green. So those are the types of events that occurred in TRA2P, only 150 events overall. But again, one of the best studies to evaluate what's going on in this population. Those patients were then treated with surgical bypass in the right panel in orange. In yellow is surgical thrombectomy. And then in lime green, again, is endovascular care. What happened during hospitalizations, just remembering how big of an impact these patients, or this event, acute limb ischemia, had. 4% of patients died. 18% of patients who had ALI had to have an amputation during hospitalization. Many had to be in the ICU, and many underwent surgery. When you look at outcomes overall, many of these patients, 12% died during the course of the study, and then many others had MACE events, amputation, other hospitalizations. Lastly, Vorapaxar did have an impact on all of these facets of acute limb ischemia, including graft thrombosis, in situ thrombosis, and stent thrombosis. So someone can update me. I told you the calves were losing. There's a large variation in how antiplatelets are used in PAD. The last one is that Vorapaxar does reduce the incidence of acute limb ischemia as well as peripheral revascularizations. There is a hazard of bleeding that is significant with gusto moderate to severe classifications. Thanks for your time.
So rather than just stand here in front of a blank slide for 10 minutes, I thought I'd talk a little bit about the role of anticoagulation in the management of risk in PAD patients, in treatment of claudication, and as an adjunct after revascularization. And then we'll go over a little bit of the data on the new oral anticoagulants in acute coronary syndromes. So the current landscape is that there's no evidence-based support for anticoagulant use in preventing vascular disease events in PAD, and no evidence for it in treatment of intermittent claudication or critical limb ischemia. The data for anticoagulants as an adjunct to revascularization are a little bit more confusing and sparse. So the rationale for anticoagulants in preventing vascular events really comes from the literature on coronary artery disease. And I've shown you here a meta-analysis of more than 20,000 patients with established CAD who are on VKAs compared to either control or aspirin. And in the interest of time, I'm not going to go over these results except to say that there were decreases in death, MI, and stroke in patients who were treated with vitamin K antagonists, but at the cost was bleeding. And so when our guidelines that Heather talked about came out, the authors said there's insufficient evidence to recommend oral anticoagulant to reduce risk in PAD patients. And then the WAVE trial came along and really put the nail in the coffin of anticoagulation for PAD. So there were no differences in primary outcome of MI, stroke, or cardiovascular death, and increases in life-threatening bleeding. And so when the guidelines updates were issued, again, there was a recommendation against anticoagulation in PAD to prevent events. So what about anticoagulants for claudication? The Cochrane reviewers looked at 800 patients on various anticoagulation regimens and found that there were no improvements in pain-free walking distance or maximum walking distance, but an increase in bleeding, especially with VKAs. So probably not useful in claudication, and certainly no recommendations for it. So a little different story as adjuncts to bypass. Again, the Cochrane reviewers looked at about 5,000 patients who are undergoing infrainguinal bypass, and they found that patients with vein bypass grafts had improved patency with VKAs. Low molecular weight heparins did not affect graft patency. And they concluded that patients with vein grafts may be more likely to benefit from VKAs, but still that the evidence is not conclusive, and so clinicians have to weigh the risk of bleeding. Nevertheless, in our patients who are at particularly high risk for graft thrombosis, we may want to consider anticoagulants. So in my world, I treat a lot of venous thromboembolism as a vascular medicine specialist. The world has changed a lot now. We have these new direct-acting oral anticoagulants, or DOACs as the preferred terminology is today. And you can see I've listed the ones that are available here, approved by the FDA in the United States. Dabigatran, which is a direct thrombin or factor IIa inhibitor, and then rivaroxaban, apixaban, and edoxaban, which are direct factor Xa inhibitors. And you can see the FDA labeled indications: non-valvular atrial fibrillation, prophylaxis of VTE in ortho patients, and then venous thromboembolism treatment. And these are terrific medications. So routine monitoring is unnecessary. They have a rapid onset and offset of action, so no bridging is needed. Very few drug interactions, and they have very predictable pharmacokinetics. So you can imagine why there's a lot of interest in these medications for other indications. And the rationale in atherosclerosis, so you saw in Dr. Banerjee's beautiful illustration on the left how thrombin plays into platelet activation. And DOACs inhibit thrombin generation at really key steps of the coagulation cascade where everything comes together. And they also have a good safety profile with respect to bleeding. And you can see here a picture of the coagulation cascade, and there will be a quiz on this later. All right, so what's the evidence? So dabigatran was studied in patients with acute coronary syndrome. These were patients on dual antiplatelet therapy, and this was a dose escalation safety trial. And the primary outcome, obviously, was bleeding. And there was found to be a dose-dependent increase in bleeding events with no appreciable reduction in MI, stroke, or cardiovascular death. So this is obviously a problem. And then there was some suggestion from the atrial fibrillation trials that there was an increased risk of MI with dabigatran. And this seems to have been borne out at least in a couple of systematic reviews looking at the various trials. Apixaban was studied in acute coronary syndrome in the APPRAISE trial, which randomized more than 7,000 patients to full-dose apixaban, so this is what we would use in atrial fibrillation and also in venous thromboembolism treatment, versus placebo in addition to the standard antiplatelet regimen. And this study was terminated prematurely because of an increase in major bleeding with no counterbalancing decrease in recurrent ischemic events. And you can see some of those bleeding events there. Finally, rivaroxaban was studied in acute coronary syndrome in the ATLAS trial, and this looked at 15,000 patients who are randomized to low-dose rivaroxaban, so lower than what we use in atrial fibrillation or venous thromboembolism, versus placebo in addition to standard antiplatelet therapy. And the primary efficacy endpoints were a composite of death from cardiovascular causes, MI, or all stroke. And so you can see here the Kaplan-Meier curve showing favoring rivaroxaban in preventing events, with some increased bleeding, so increased TIMI major bleeding not associated with CABG, and increased intracranial hemorrhage, but overall non-significant increases in fatal bleeding. So that's where we are now with acute coronary syndrome. You'll notice that I didn't mention anything about PAD in the DOACs or critical limb ischemia in the DOACs because there's really nothing out there. The COMPASS trial, however, is recruiting currently, and this is a trial of low-dose rivaroxaban in patients who have established coronary or peripheral artery disease. And PAD is defined as previous lower extremity bypass, revascularization, limb or foot amputation, intermittent claudication, a low ABI or a hemodynamically significant stenosis on imaging, or asymptomatic carotid artery stenosis more than 50%. And the primary outcome is, again, it's not a prevention of or a treatment of critical limb ischemia, but prevention of vascular disease events. And so the way this is going to work is patients are going to be randomized either to low-dose rivaroxaban 2.5 milligrams plus aspirin versus aspirin, or rivaroxaban 5 milligrams alone versus aspirin. And so we're eager to see what that's going to show. So in conclusion, there's no evidence as yet for the DOACs in critical limb ischemia, although the rationale in reducing platelet activation is certainly appealing, and the ease of use of the drugs is certainly appealing. The benefit of DOACs in preventing recurrent ischemic events in acute coronary syndromes is real, but it's at the cost of increased bleeding, and this is unclear how it might translate to PAD patients. And so I think the final message is that trials in risk reduction, as well as adjuncts to bypass and revascularization, are severely needed. And with that, I thank you.